My specialist area is prosthodontics, which is replacing missing teeth, which fits perfectly into what we're doing today, which is, I guess, why I've been asked. And what I say to patients when they come along, even if they're coming along for implant consultations, is, listen, all I'm interested in doing is helping you to resolve your problem. You've got a gap there, we need to help you replace the missing teeth, and I'm going to look at that with an open mind. I'm going to look at it from the point of view of crown and bridge work, implants, dentures, whatever. Let's find the thing that's really going to work for you. And then from that communication with the patient, we can then move on and actually point them down the right pathway. And that may be to other guys in the practice, it may be back to you as general practitioners. But it's really managing the patient to really meet their expectations. So what I'm going to do today is I'm talking about dentures. But first of all, a couple of thank yous. The thank you is for being invited to speak today, and the second thank you is for cancelling it last time. Because the snow, as everybody knows, last time was the reason it was cancelled, and I got the opportunity to go snowboarding up at Glen Sheep the first time in about 4 or 5 years. So thank you very much. And I mean, it was a superb day. I was meant to meet Paul up there, but he spent most of the day digging his Land Rover out of snow, having to slid off the road a couple of times. But we communicated by text, and I was on the top of the hill telling him how wonderful it was. So a great day. Anyway, removable tooth replacement options. We have a problem, don't we? Because what we're talking about here is dentures. And the problem is your problem and my problem, because dentures are not very exciting. And you've got me for the next sort of 40 minutes or so to talk about dentures. They ain't sexy, but it is something we're all going to do every day. And so I'm assuming that everybody here has a basic level of knowledge. You've all been through undergraduate training, and every day you're all doing dentures. Be that 2 15-minute appointments with an alginate, or doing bite blocks, taking through try-ins, you all have a level of knowledge. So what I want to try and do is try and give you an idea of techniques that I do, that I've spent the last 10, 15 years trying to perfect and tweak in order to make life better for the patient. Because that ultimately is what it's all about, isn't it? So really what we're going to talk about today, I'm going to attempt to talk about, is the interesting bits on partial dentures. How about this? Here's a patient who's had an awful life. These are the patients, they walk in the door, you look at the OPG, you look in the mouth, you know this person has spent an inordinate amount of time in the dental chair, and they're back again. And the day has finally come when these teeth have to go. Somebody has to put their hand up and say, listen, you've had enough dentistry, it's not working for you anymore. Let's not keep doing this, let's move on, okay? So you can sometimes hang on to roots. Implants are not suitable for everybody, so why not hang on to roots? Don't take them out. Okay, if they've got post-crowns in here, just cut them straight off the necks. You've talked to your laboratory, and they've made you an immediate denture. That's a very positive experience for patients. They're walking out the door smiling, everything's working for them. Yes, it's a denture. They're now in a position whereby they have confidence, they have their dignity. People outside of the family don't know anything's really happened. If anything, they're getting comments saying, hey, you're looking good, you're smiling more, what have you had done to your teeth? That's not the usual denture experience. And then in the future, if they want to, they can move to implants. But that's their choice. So, how do these things fit? At the end of an appointment, can I just pop one of these things in and they fit? Well, the first thing is your lab. When you send a job off to the lab for a partial denture, by and large what's going to happen is they're going to process the denture the way they do every other denture, and they destroy the model when it comes out of the plastic, and so you get a denture back in a little bag with a bit of water. Now, we all remember from dental school what they should have been doing was surveying the models, blocking out the undercuts, making the denture, and then refitting the denture to a hard model. That never happens, because that would add another hour anyway, which would quadruple, if not triple, the price of your denture, so it just doesn't happen. But what you can do is, if you ask the technician to think about it in an undercut situation, he can make a duplicate model, and then he, rather than you, can trim the denture and fit it to the duplicate model. So that when you get it, it will fit in the patient's mouth, no question. That's a nice thing to do. It saves a heap of time. People say, well, it costs a lot more, I might spend 20 quid more on a denture. Well, you might, but what price is half an hour of your time up to your elbows and blood spatter and all the other stuff when you're trying to adjust dentures in and out of the mouth and it's bleeding? So I would suggest maybe having the lab spend a wee bit more time, confidently, because you know it's going to work, so you spend less, and it's less stressful. Now, if you're going to do an immediate full upper, for example, you've taken the teeth out, You're not quite sure what the tissue's going to do. The technician has done their best, but it's hit or miss. We know it's hit or miss. How can you treat that situation so that when the anaesthetic wears off, the patient isn't immediately going, it really hurts, it's rubbing this area? How can you do the high spots? What we've been given, what we've been told to use are these pressure relief creams. If you try using those after immediate extractions, there's kind of blood everywhere and there's kind of stuff everywhere, and it's just a really messy, unpleasant experience. Why not use a thin layer of alginate? You get your technician, your nurse, to mix up a very thin liquid layer of alginate, and you can put that into the denture, fit the denture into place, let it set, it takes a few seconds to take it out. And what you'll see is, up here, I'll take a pen, and in there, there'll be a high spot, and I'll mark that high spot, and I'll trim it. And then you just peel the alginate out. Get your mark there, just peel it out and adjust it. And you can do that a couple of times. It's a nice, easy thing to do. So the next problem you've got is, you've adjusted it so that it's not going to rub, it's not going to cause any problems. How about the fact of getting a tight fit? We don't really want to go down the road of clasps, do we? And a lot of people do that as well. We know the denture's going to drop out, so we want to stop that, so why don't we ask for some clasps? Patients hate clasps. Adam's crib, they hate it. It spikes in their gum, they don't like them. They don't like the look of them, they don't like the feel of them. So let's avoid the clasps. Now some of you might be using this. If you haven't, please bear with me. This is a great material. It's called Tokiyama Rebate. There's another material out there by Voco, I think it's called Ufigel, which works much the same. These are non-exothermic reline materials, and you can use them for all sorts of things. But for me, what I'm using them for is relining fulls, but also partial dentures as well I'm using them for. I've even gone so far as to actually build an immediate denture with this chair side. So it's a great material, you can use it for all sorts of things. I've added teeth to dentures. It's a lovely material to work with. And I'll show you how we work with it. It's easy me standing here saying, use this material, it'll work for you. And then you get caught up in the guddle in the surgery thinking, what the hell did I do with it? So I'm going to show you. It's going to take a minute or two to play. I might speed it up. We'll see how we go. This is a duplicate model. And for your benefit and delectation, I've attacked my denture, which would have actually dropped into the patient's mouth and stayed quite nicely. I've taken a straight burr to it and cut lumps out of it so that it's loose. So you could do this chair side. You could get your denture back as you do from the technician now, and you could actually cut lumps out of it until it just goes straight into the patient's mouth and not worry about the big gaps. Okay, because you're going to take our material, and it comes as there's the three parts to it. There's the adhesive first of all. Excuse my hand, it's challenging being the cameraman and the operator at the same time. There's three parts. The first is the adhesive. Despite it being a cold cure resin, you require an adhesive to really get the bonding going on the material. So where you're thinking of putting the adhesive, where you know the gaps are and you want some adhesion, roughen it up with your straight handpiece, and then put the adhesive on it. And you just let that air dry. Very straightforward. And the next step is to mix up the material itself, just a powder-liquid ratio. And the ratio is a 2 to 1. That's that you can use this for a complete denture. I'm using it for immediates, but if you have complete dentures that you're doing, the patient comes back in a year down the line, 2 years down the line, and the thing's moving, and you're thinking we'll do a reline. And then you think in the back of your mind, I don't want to do a reline because I'm going to send it off to the technician, and then the denture they like is not going to fit anymore, and it's going to be my problem, not their problem, and it's going to cost me, so I don't want to do a reline. So you send them off to the tube, fix it again. This stuff works really well, because what you see is what you get when you do a reline chair side. They've already got an occlusion that works for them. And you see how this stuff mixes up? It mixes up into a really beautiful material in that it immediately absorbs all the liquid. It doesn't go clumpy, so it's going to flow underneath the denture when you put it into place. And what I'll do is I'll paint it on where I want it to be. I'll let it set a little bit and I'll paint it on to where I want it to go. Because it has about a 3 or 4 minute set time. So it's totally chemically cured. It doesn't raise any heat. So as it starts to kind of just stiffen, I'll put it into where I want it to go. If you're doing it on a complete denture, obviously take your straight handpiece right across the whole surface of the denture. I'll run it in again until it's just about right. Place it in the patient's mouth and get them to bite together in the occlusion they like. And then on the outside, you can actually hold the lip out of the way, take your finger around and take away any excess so it doesn't run over the edges. Or you put Vaseline on the flanges on the outside so you can just flick off any excess. take it to the patient's mouth, pop it in, place it down into position, and then do exactly as I'm doing here in this model. And that I'll just wipe away the excess with my finger. Now, it's always wise with any of these chemical pure materials to put some in the back of your hand when you start mixing it, isn't it? So you get some idea when the stuff's going to go off. You can set timers and things, but it's nice to know when this material's going to go off. I read an article in an old journal I was looking up dentures, and they said you should put some in your mouth. Okay, we've moved on from there really, haven't we? But you can see what they're getting at, in that we've all done it, haven't we? We've all cured something in the mouth and then thought, oh, and then you spend the next half hour or so trying to cut the thing out. So you'll get an idea when it starts to go in a kind of a go stage, and then you take it out. Now it's up to you. If it's a heavily undercut situation, then you're going to take it in and out a few times while it sets. If there's not much undercut like the case I showed you before, then I might just take it out once, put it back in, check it's coming out, leave it a little bit longer, take it out and stick it in hot water to finish curing. And the hot water will just zap it cured. So it does have an issue, it will cure very quickly. Then I'll take away any excess. If there's any little bits of flash, then I'll just kind of remove that quite quickly. At that point you put it in, it will then clip into position, there's no question, and it won't fall out. So now you've got a denture that is tight, clips into position, didn't take you much time to do it, and you've got a happy patient. There's no bits of wire. So it's a really nice thing to do, it's a nice material to use. And as I said, you can use it for your relines, for completes. Even if you've got patients where you've done partial acrylics for them, and it's years down the line, this kind of rehabilitates that denture, because we all know that getting into making new partial acrylics can be a minefield, and it's certainly not a winner in the patient, and you can lose a lot of money at it. So this kind of helps you out. Okay. You've been there.
Super glue kit.
That was because I wasn't sure I was going to get that get it off the model at that point. I get to being operator cameraman, but the timing as well.